Hey, welcome to day 2. I hope you all had a wonderful time yesterday. I know I did. That's not necessarily an indicator. But the fact that you're back is an indicator. So thank you for coming back. Before we start, I want to be sure and let you know so that when you see them and here in the room and during the day, you can thank them. But we have some amazing sponsors that make this really possible. Microsoft, Frank Torres, ID Experts, Bob Gregg, who's right up there, and Christine, is she here? Maybe not yet. Jericho Systems, Bryn Mao and Vince Cruz, and I don't see them here yet. IMS Health, Kim Gray, wave Kim, and Bob Hunkler, thank you so much. Park Legal is not here today, so I will thank them. Meditology, Cliff, are you here? Cliff Baker, Ankit, here's Ankit, thank them as well. And NetApp, Jessica Jorgensen and Dave Nizvisky. I don't see them yet, okay. But so when you see them, please tell them that you appreciate them enabling us to be able to do this for you, feed you, be here, the whole thing. So thank you very much to our sponsors. So welcome to day 2. We've got a really exciting day for you. And don't forget, we're going to have a wonderful lunch. And Adam Tanner is going to give a keynote there. We've got a lot of great panels and discussions lined up for you this morning. And so I think I'll just get out of the way. What do you think, Sahid? Okay, all right. Andy?
Yes, please. So we are having Michelle Mooy of Consumer Action and Kim Gray of IMS. And we've been exchanging email up until 10 o'clock last night, so we've decided to have...
Good morning. Nice to meet you.
Yes.
Good morning. Nice to meet you. Hey, Andy. How are you?
Decided to have a suitably chaotic debate here. The debaters have said that they would prefer to have a friendly conversation rather than debate. I'll try to push them a bit toward a debate, but anyway, it will be an interesting view on something we've talked about a lot, which is whether patients should have control over their own records. I think the idea of patients controlling their records has certainly gone back decades, as people would maintain manila folders and they'd stuff x-rays into big folders and keep them in their basement, stuff like that, all because their doctors wouldn't give this to them. And I think back in those days, that was sort of an acceptable way of behaving. There was a time when if you hired a wedding photographer, the photographer would keep all the negatives, pre-digital era. When you wanted a print, you always had to go back and try to track down the photographer and ask for your prints. And this was accepted. But even then, the photographer, I don't think the photographer had a right to sell your prints to anyone they wanted, as long as they kept your name off of it. And certainly when you went back to the photographer, you didn't have to say, I'm a 26-year-old female living in Silver Spring. Did you happen to have any prints that match? So that was acceptable for the medical industry, but it's not acceptable any longer. So the people who maintain their own records just as a way of taking back some control from the doctors have been joined, of course, by the quantified self movement. And this has been a very powerful development because now the patient has data that could be valuable and that the doctor could need. And we are going to see whether the doctors can open up their systems and whether the EMR vendors can open up their systems to make this data approachable. And a third element worth discussing is segmentation, where the patient can control who gets the data. Now, I did not remember to flip a coin, so I'm just going to let you go first. Each of the debaters will have 5 minutes to discuss whatever they want, and then I have 2 questions. I kept it down to 2, so we have plenty of time for some in-depth discussion. All right.
Hi, good morning. My name is Michelle Mooy from Consumer Action, and just briefly, Consumer Action is a 44-year-old national nonprofit, and our mission is to empower consumers in the marketplace, and our focus is on underserved and disadvantaged communities. So lots of what I say has that lens on it. I'm really thrilled to be here today to speak with Kimberly about such an important topic. I was all for the debate. just so you know, I'm a big fan of debates. I was a debater in high school, although I was a terrible debater, so hopefully I'm better. But regardless, I think there are some opposing viewpoints that we can bounce off each other, whether we debate them or not. So I think patient control of clinical data is ethical, efficient, and probably most importantly, inevitable. I think of it as kind of a freight train that's coming towards us and is not going to stop. Consumers are already doing so many things online with sensitive information, bank accounts, investments, all kinds of stuff. And the expectation is that they should be able to do this kind of management with their own medical records as well. And I think the expectation is snowballing. 5 quick points that I want to make is accessibility. And accessibility isn't just about accuracy and data accuracy, although I know that's really important when patients have control, but it's also about inclusion. And there's that lens of underserved communities. When patients have control, it leads to more inclusion with underserved populations, and I have tons of data that kind of proves that. It may not make a whole lot of sense, but there are tons of studies and surveys that show that people in underserved populations are more likely to use mobile devices, more likely to engage with the doctor if it's remotely, et cetera. Also, inclusion then leads to better outcomes and participation. So that's something that's sorely lacking, obviously, in the system right now. There's not a lot of trust. There's not a lot of inclusion. In fact, it's really just a fragmented system. Personalization is another outcome of patient control of records, and personalization leads to more responsive care. It's more one-on-one. In fact, they did a study, and patients who had a virtual visit with their doctor actually felt heard more because the doctor was paying more attention to them because they necessarily had to be able to engage with the patient. Personalization is also a business concept that is, gradually sort of dawning on the health industry as well as being an important part of sort of the market share, the market advantage of patient control. Cost treatment and efficiency and accountability via transparency. And I can't say enough about accountability. And that's particularly important with those within the health data broker industry like IMS Health. There's so much that we don't know about this industry. And as consumers, no matter what we say today, that really strips us of control. So unless you know and have the ability to consent to any information that's taken or used, any personal information, medical information, regardless of if it's de-identified later, there's so many also studies that show that that's virtually impossible to de-identify, particularly with sensitive things like health data. So accountability has to be in play in order for patient control over medical records to work. And I want to also add, it's not just about the control, it's about the permissions, it's about the creation of it, the modification, the dissemination, the use, and the deletion of the record. These are all really crucial parts of patient control. I can go on, but I don't know if I have time.
You have about 90 seconds.
90 seconds, okay. Well, I mentioned the public's trust eroding in medical records, and why shouldn't it be? Because under current laws and practices, identifiable medical data are routinely shared with insurance companies, government, researchers, employers, state bureaus of vital statistics, pharmacy benefit managers, local retail pharmacies, attorneys, gyms. And all of these things have sort of weaseled their way through loopholes in HIPAA. And it's gotten to the point where people actually act contrary to their best interests in terms of healthcare. They won't, they'll hide things, they'll go to different doctors for different things and hide one record from another. And of course, this is all inimical to the goals of healthcare itself. That's not something that we want to keep going down that road. And I think one of the most important effects of patient control is, again, just taking the health data broker industry out of the darkness. If you've read the recent FTC report about data brokers, it does a good job of kind of giving the public an understanding of what data brokers are. But there's been nothing like that in the health industry. And the industry fights very, very hard to keep that information to itself. And they have lots of reasons. But when you have companies like IMS Health that have apparently 100,000 data suppliers covering 780,000 daily data feeds, that's much larger than the data broker industry that the FTC was looking at. So people want and need to know what's happening to their data and how it's being used in order to effectively control it.
Thank you.
Sure.
Jim.
Hi, I am Kim Gray. I'm the Global Chief Privacy Officer for IMS Health. Prior to my tenure at IMS, I actually worked in an identifiable world. I worked for a very large Blue Cross Blue Shield plan. My work at IMS, however, is primarily in the de-identified data world. My belief is very similar, actually, to Michelle's around patient control of identifiable data, and that's why I think Andy made his comments early about not sure how much of a debate this is. And while I'm very interested to speak here this morning and to give my perspective, I don't think we're as far apart as everyone might believe. I'm not quite sure what the assumption was about my position, given that I work for IMS, but IMS has always been a patient advocate. It's been in business for more than 55 years and developed a de-identification methodology long before HIPAA thought of the word and long before it was a requirement. And as a matter of fact, it's not required in our world, in our business. We're not a covered entity. We're not a plan provider or clearinghouse, yet we still do that as a patient privacy protection. One of the things that I really like about my position is that I feel that I work for an ethical company, and I've been there 5 years now, and trust me, I wouldn't stay at a company for 5 years that I didn't believe to be an ethical company. I've been in healthcare all of my life. I have been on the clinical side of things. I was a nurse before I went to law school, so I see things from a patient perspective. Once you look at things from the patient's perspective, you have a tendency to always think of patient first. And I'm a patient sometimes, and so are my family members, so this is all very important to me. And I don't believe patients should be cut out of the equation. I think patients do have a role to play. I think it's more of a partnership role along with their healthcare providers. I don't believe that the old, antiquated, patriarchal way that we used to do things, where doctor knows best, is the way that we should be moving forward. I absolutely believe patients have a role to play. I also believe that it's very important that we share information, because information sharing is the currency that we need to keep the healthcare system alive, but more importantly, that's the information that the doctors and the patients both need to be able to have the best care possible, and to make sure that we are not having disparities in care, much to Michelle's point about underserved populations. Better data, more data about patients and the populations only serves to help everyone, not just the individual patient, but from a public health perspective and from a societal perspective as well. I believe that an important way to do the data sharing, however, is through de-identification. And while there is no such thing as never being able to re-identify something, I don't care how anonymous you make something, someone somewhere, somehow can probably figure out how to break into that, because we have people whose jobs it is. LaTanya Sweeney, for example, is a wonderful computer scientist who could probably be given certain data sets, and with an attempt to re-identify could probably do so. However, it's not nearly as easy as some of the pictures have been painted. If data is truly de-identified, and I'm using that as a HIPAA term of art right now, if it's truly de-identified, it's not easy to re-identify it. It's not impossible, but it's not easy. And I think at some point we have to accept that there's a little bit of risk in everything. We can leave here today and be hit by a cab, by a bus, by a whatever. There's risk in everything we do. I think that it's very important, however, to manage that risk to the extent possible and to the patient privacy protections possible as well. I make a big point of saying if something's properly de-identified, because there are plenty of organizations out there that now use the word de-identified or anonymous as synonyms. And they're not necessarily doing things to a level that, say, HIPAA would say was de-identified, or that my company or others who do this, sometimes above and beyond what HIPAA requires, the data is not truly de-identified in many cases. So if you're able to re-identify in your AOL or Netflix or any of those other ones that we've all heard about, it's easy to see where they weren't doing such a good job in the first place. My position is we should be doing de-identification, making better use of de-identification, but doing it well. And testing that and constantly trying to improve things by continuous process improvement, by having experts come and validate later that what you're doing is satisfactory. Because at the end of the day, if we're going to have patient breaches, and we have the HHS wall of shame we've all seen, heard about, where companies have not done a very good job of protecting data when it was identifiable, at least if it's de-identified, you're cutting down tremendously. And I think it's very important for de-identified data to be able to move the ball forward, and at the end of the day, with what we learn, to be able to help patients too.
Thank you.
Can I ask a question?
All right.
Quick question. When you say that you de-identify data, are you saying all of the data that IMS Health holds is de-identified?
Not all of the data. We do, in some cases, act as a business associate for some covered entities. That data is housed in an entirely different environment, different controls, different people, and that's part of what I'm talking about. When you're de-identifying, you've got to treat that data with due care. And so we actually use administrative, technical, and physical controls, sound like a HIPAA word for PHI, around our de-identified data. We believe it's very important that you have firewalls. The same people are not working in the de-identified data. In fact, the same people who do assist with the data coming in that is de-identified are not the same people who work with it after it's de-identified, and they're certainly not the same people who ever come in contact with identifiable data.
Okay,
and that's a
just
very
one more quick-
confined world.
What kind of data do you collect on people that's not de-identified?
Data that's not de-identified but would be whatever the covered entity would want us to be acting as a typical business associate for.
So, like, what would be an example of something that, is it social media data, diagnoses?
No, presumably it would be most of the covered entities that are having us work as business associates are looking at us to do analytics.
Analytics.
So, it's whatever the covered entity has that they want us to do an analysis on.
So how quickly after so say you're getting something for a clinical trial and you get de-identified data, but how quickly is it then identified or identifiable when you're saying, here's a group of people that would work for this clinical trial?
No, we're talking about apples and oranges right now, so that's kind of difficult to answer. Clinical trials have nothing to do with what we would be doing as a business associate.
What would your part in that kind of thing be then?
In which thing? I'm sorry.
So if you have a pharmacy company that comes to you and says, we want you to gather data.
A pharmacy or a pharmaceutical company? You said pharmacy company.
Pharmaceutical.
Okay.
I'm assuming you have pharmaceutical.
Some of our clients are pharmaceuticals.
Yeah, and forgive my ignorance. It's it's difficult to get information about your company. I had a little trouble. So
actually, I apologize, but we've been in a quiet period where we've not been able to speak because of legal reasons. So
gotcha,
yes,
gotcha. Okay, so in this example, you have a business associate. You're a business associate, or you have a contract with a pharmaceutical company.
We would not be a business associate for a pharmaceutical company. So let me give you a little HIPAA 101.
Okay.
To be a business associate, you have to be working on behalf of a covered entity involving the use or disclosure of protected health information. So covered entities are healthcare plans, insurance companies, providers, doctors, hospitals, that kind of thing, and clearinghouses that allow the transactions to go back and forth between a provider and an insurance company, for example, to pay claims.
Okay.
So a business associate would only be working on behalf of one of those three kinds of things. That's a term of art that would have nothing to do with clinical research.
Okay, so you have a pharmaceutical company as a client, and they ask you to gather data about this type of illness from people who are like this, and then in a geographic area. So you have 3 or 4 data points about people that you share with them. Is that right?
We could.
And so if they're looking, for example, say their purpose is to enroll them into a clinical trial or whatever they're going to do with it, there's a point when that data is identified, correct?
When it leaves the pharmacy, before it leaves the pharmacy, it's de-identified.
Okay.
The de-identification software, the engine, is actually done in one of 2 ways. It's either installed at the pharmacy or at the data suppliers, so that before it ever leaves, it's already de-identified, or it goes through a trusted third party that's acting sometimes as a business associate on behalf of the pharmacy. When it arrives at our shores, it's already de-identified. No, it is never identifiable when we receive it. It's not identified once we have it. That's one of the major things about why we put so many controls in place. No good can come from us wanting to re-identify de-identified data. That's the whole point. We don't want it to be re-identified.
Sorry.
Okay, and I think there is a big difference between the clinical trials where they probably go right to the clinician, and this is why they're often associated with an academic institution doing medical care. Difference between that and doing big data analysis on supposedly or truly de-identified data. So I have a question which I think will launch a lot of interesting discussion. Suppose that we have reached this point where the patient controls the data, where most clinical data is not stored by the physician, or if it's stored there, is under the control of the patient. And all the researchers who are used to going to the clinician and buying data now have to ask the patients, either on a case-by-case basis or through some kind of global permission. So how will this affect the clinical trials, and how will this affect the relationship between the individuals who are the subjects and the clinical trials? So I'd like to reverse the order now so Kim can start.
So just to make sure I'm understanding the question, if patients are controlling their data, what's the effect with clinical trials?
Yes.
It's hard for me to understand patient control, and I think we have to define what patient control is exactly. Because at some point, there's a difference between patients having 100% control and patients having a partnership. So perhaps some kind of, finesse as to what we mean. My concern, though, is if a patient has absolute control and it's not a partnership, then we're going to have some problems with clinical research. I don't believe we would be seeing as much clinical research. We would have selection bias. We'd have only certain patients wanting to participate. Those who maybe have something that they're embarrassed by, they want to hide, would not participate, even if the data was well protected. And when you have selection bias, then you have skewed results.
Okay, Michelle.
Well, first of all, I think one of the big problems, before I go directly to answering that question, is that the vast majority of research on health data is totally and completely hidden from patients. So, not only do patients have sort of we have a complicated history with research in our country, if you think about Tuskegee and other situations like that, but also Americans are routinely lied to by these data brokers, and a lot of times they will pose as researchers in order to get some information about you. So, I think industry research of the type that, IMS Health or others do is really business analytics and selling data profiles, using it to find patients, to target patients, to, sometimes it's for solely business reasons, I think, and sometimes it's for societal good, new drugs and treatments, et cetera. But the key is that the control part doesn't exist at all currently because it's not transparent. So, it's one thing to sort of for us to conjecture and say, patients are going to self-select and they're going to do this and that and the other thing. From my understanding and from things that I've read, patients, it's actually the exact opposite. People really want to share their data, are very altruistic when it comes to that, believe in the benefits of medical research for the population. But the people who want to hide embarrassing things, well, they ought to have the right to do that.
And I don't disagree that somebody who wants to hide embarrassing things should have the right to do that. That's one of the reasons I'm a proponent for de-identified data. I would not want someone's personal information to be an embarrassment for them. But I'm troubled by some blanket statements you're making where you're lumping IMS in as these data brokers and making comments that we're trying to hide things, that we're trying to target patients, that we're not doing real research. If you would go to our website and take a look at the real research that we have published, we have a bibliography of I don't know how many studies that we've done in conjunction with very well-respected organizations, academic institutions around this country, and along with, say, the CDC and FDA and others. It's very real research showing very real results that could be very beneficial, showing real-world evidence of how things really work, not just how they work in a clinical trial pre-launch of some medication or something. And this data is extremely helpful from a public health perspective. tracking what's going on with, there was a presentation for those of you maybe that were at the Health Data Palooza earlier this week. There was a presentation that showed the flu tracking and how one could see pockets of where it was showing up, first in the Northeast and then in the South, and then how it was coming and going. That kind of thing is very important. It's very real research. No one's trying to hide anything. In fact, as I've said a million times, we're very patient, privacy protective, and that's the reason for doing so with de-identified data and not with identifiable data. I'm not sure who the other data brokers are and what their concerns are. I can tell you the FTC report was involving identifiable data. I don't think any of us would disagree that more transparency is needed, accountability is needed, but I think to lump everyone together is just terribly unfair.
So you think asking patients for consent should not occur?
I think consent needs to be meaningful, and I have concerns that most consent these days is not meaningful consent. And if we show up at a doctor's office and we're handed a form and we're told, here, you need to sign this, and we're in a particular position where we don't have a lot of choice, to me that's not meaningful consent. So if we don't have meaningful consent about things, it just becomes a paper exercise. And at some point, if it's not meaningful, then I think that a better way of looking at it is, at least if we're trusting our data to different organizations, we should be able to trust the organization. And we do this all the time. As long as the organization is transparent and accountable, we give the trust, and that's what we propose.
Okay, but IMS Health is neither of those.
That's not true.
Well, okay, so you would be willing to publish something that explained and went through all of your practices and every, sort of market share that you have, every tiny specific piece of data that you get from consumers, from patients, and why these people are not asked for consent for this?
They're not asked for consent because that would require identifying them, and we don't want to identify them. We're getting the data already de-identified. And so therefore, it would be ludicrous to go backwards and try to identify them to get consent.
I think it's ludicrous that you seem to think that you have more of a right to the data than the people whose data it is. In the sense that, well, no, we can't ask your consent because we're de-identifying it. Well,
we aren't de-identifying. It's coming to us already de-identified. That's key. So for us to be able to go and get patient consent would require re-identification to find the patient, which we can't do. And
So we have to return to the clinician or the payer who gives the data originally, and then talk about whether it's right to release de-identified data without consent, or if there's better ways to get consent.
And as you mentioned, that there are parts of IMS Health that do collect data that's not de-identified, correct? Do you ask consent for that data?
It's covered by HIPAA, and consent is not required because we're acting as a business associate, which is a perfectly legal way to do things. There's contractual prohibition. I personally think it is. I think that our data is handled by covered entities and business associates all the time for legitimate reasons, and I think HIPAA does a pretty good job of covering things. I noticed one thing you said in your opening was that people were weaseling their way through loopholes in HIPAA. I think the truth is, it's not weaseling through loopholes in HIPAA, there's an awful lot of health data out there that's not covered by HIPAA. So HIPAA, again, is covered entities, plans, providers, and clearinghouses. There's a whole lot of other organizations out there not covered by HIPAA. That's not a HIPAA loophole. That's a problem where we have health data from gyms, from health, whatever it happens to be, that's not covered by HIPAA at all.
Right.
Some organizations still follow HIPAA even when they don't have to. They go above and beyond the requirement, and that's what I'm talking about. Much of what we do goes above and beyond what we have to do because we are ethical and do believe it's the right thing to do.
I think HIPAA has a lot of strong points, but yeah, I think it's got a lot of weaknesses too. I think anybody who has studied the law and the law in action, especially in the last maybe 10 years when technology has sort of overtaken a lot of this impact of HIPAA. And weasel, I think, is the exact right word for companies who really don't want patient control, don't want consent, because they want, the legitimate reason is money, right? I mean, that's the whole point of it. So I think that would qualify as weaseling.
Yeah, my only point was it's outside of HIPAA, though. The organizations are not covered by HIPAA. So it's not really loopholes in HIPAA, I think, that are the problem. It's that we should be very much concerned about those that are not regulated by HIPAA.
Now, I'd like to look again at the question I asked about patient control over data, because I really kind of violated the clarity that Kim was asking for. I talked about clinical trials, which of course use the full patient record and often the patient herself. So that was not de-identified data. But it's interesting to talk about the patients having control over data in situations where the clinicians want to use the de-identified data. They want to do some kind of analytics. And here, I think, as Kim was saying, the patient, if the patients have to be asked every time, this could cut down on research, or it could lead to other ways of people doing research. It would be interesting to see whether researchers would change the way they recruit and deal with patients in order to get more of the data.
Mm-hmm. Good point.
So, no particular response. I would also like to mention that there was, I didn't mean to take over the conversation, but I should mention that we had a keynote speaker, I think at the very first privacy conference, who pointed out research that most patients, as Michelle was saying, would like to share their data, but they want to be asked. They don't want it to be done without their consent. Deborah, who was that? The speaker? Alan? Weston, that's right. Yes, right.
Yeah.
Yeah. But let us look a bit at this de-identified data, and I do believe that there are reasonable standards for de-identification. We have some debates here about how much it can be re-identified. But what are, let's take a look at some of the, I'm still looking at the consequences of patients being able to choose who gets this data. Would you like to speculate about what clinicians could do, or what other research could do to get the data?
I'm sorry, I'm trying to understand the question. So are we talking about de-identification or just the general?
The patient data, but we assume that the patient would want it. I know also that talking to Khaled Al-Amam, who was here yesterday but doesn't seem to be here today, I believe that you can't really have a single de-identified patient. You have to have data sets, and then you can determine how many people are in them and what their variance is and so forth, and then de-identify it. But
well, I think sort of speaking to that, there are ways to have patient control in a way that it, offers a secure system like cyber IDs, and health record banks. I think all of these options have been developed. They're much cheaper than sort of what's out there right now. DID has been debunked, I think, pretty thoroughly. Now, I understand that there's some DID systems that are effective, and I think it's great that companies are trying to do that. But the problem comes in when using DID is sort of a wall in which to put up in front of practices that aren't revealed, practices that aren't transparent, and that don't involve de-identified data. And also, the point I was making earlier that when you have medical information in particular, which is, of course, some of the most sensitive, it's easy to identify somebody. I mean, there have been studies that have shown the places you walk within 3 steps or something can identify you because you're near a place that, is a part of your life. And so, when something like that is pretty easy to identify, obviously, the secondary uses, maybe IMS Health is using it first. The secondary use is the identifiable part. And all of this is done without anybody having a clue that somebody is looking at these detailed records about your health. I think many patients mistakenly believe that this is covered by HIPAA when it's not.
Okay, I'm not sure when you're saying secondary uses of identifiable data. It's just to be clear, once we receive the data, it's de-identified, and that's a secondary use. Any tertiary uses would also be de-identified. So just to be very, very clear, once it's received, it's de-identified, it's used in de-identified form, and it continues to stay de-identified. We, in fact, don't allow for re-identification. So you can speak to other organizations, but I'd need to be very clear that that's not what's going on at IMS Health. We are certainly not poring over identifiable records of any patients whatsoever as part of our business model.
You're selling them, right?
No, absolutely not selling any kind of identifiable records. Absolutely not. I'm glad for this opportunity, because if that's the mistaken belief about what's going on.
Are you trading them? We're sharing them?
We do not have identifiable records, except to the extent when we are acting as a business associate, and that is only in a very linear product line, very small part of the business, only working with certain covered entities like anyone else would be a business associate. That data goes back to them, not to anywhere else. We are acting as their agent, not anything else. The only data that we deal in is de-identified data.
Except for that part of the business, right?
You're misunderstanding. That's not sold. That data is not sold. We are acting as a service provider for a covered entity.
Okay.
Let me go with my understanding of what HIPAA was doing. If a hospital can't do everything, they can't do their own analytics. They sometimes can't handle payments because billing is so difficult, and so they outsource treatment, payment, and operations. And this is if they did it in-house. And so the business associate is supposed to take the data, do what it needs to do, and then destroy it or send it back or something.
Exactly right.
However, I think this was not really clear until last year. Is that right? When yes, the ONC or one of the other agencies published a rule about that.
It's actually been around since the beginning of HIPAA. A lot of organizations didn't fully understand it until high tech, but yeah, I think that's always been the premise, is that you're working on behalf of the covered entity. What changed with high tech is your own direct liability as a business associate.
So I think it's time. I wasn't going to crowdsource this, but I think it would be useful to take questions. But I'm going to ask one more question. I don't know if this is really the right group of people to discuss it, and then we can take some questions from the audience. So my final question is, the patient holds the data, the clinician does not have it, the patient can segment it. So in this situation, how does that affect the relationship between clinician and patient? Okay.
Okay. I think there would clearly be a risk of negative health consequences and records with bad data, but that risk exists now. And now it's a reality rather than a possibility. With control, I think, would come education and responsibility, and my hope is that the providers would understand the importance of helping patients understand how their permissions alter their treatment options and could impede their care in some way.
Okay.
Yeah, I don't see much difference either. I think this is one of those things where the heart of the doctor-patient relationship is a trust relationship, and if the patient is withholding information from the clinician, the patient is the one who's at risk of having misdiagnosis, therefore mistreatment. Same kind of thing as what we have today. If a patient's withholding information, not exactly telling the truth when asked about how many times a week they're having an alcoholic beverage, for example, and they're fudging that just a little bit, that can absolutely affect things. Segmentation maybe takes it a step further. If the patient doesn't want Dr. A to know about the treatment patient's getting from Dr. B or whatever, I think it's problematic today and in the future with segmentation.
But the difference is the person would own the record and have the ability to choose to show it to other people. Perhaps not this doctor that I don't trust, but this doctor that I do. Versus the way it is now, people just don't talk about it. They, won't reveal healthcare information about themselves, which is, a major detriment to their health. Whereas this gives them an option to own it and consider different providers, different options, different ways of maybe showing some limited information versus all of it.
I just am not really seeing the difference. To me, the patient still has that control today, whether they have a little chip or something that they're carrying or not. They can still choose to discuss things with one provider or another or not.
Well, we had an example at one of the previous summits of the patient Julie, who had shared some very serious mental illness problems with a huge organization with thousands of employees. And so if someone else treating her could get the information, even though they were just treating her for some relatively minor physical ailment. So that was the use case we're talking about. Okay, let us take some questions. Adrian.
Hi. I'd like to dive a little bit into the core issue that's been on the table here about HIPAA and what business associate relationships versus the identified data use, because it's clearly core to the debate. And in the opinion of both people, but particularly IMS, business associate relationships do not allow necessarily in that service provider role for aggregation across different providers.
right.
Whereas data that individuals control, almost by definition, is not specific to any particular covered entity. So when it comes to the overall goal, whether it's science or whether it's better individual care analytics, predictive analytics, whatever you want to call it, the role of data brokers and the way we use HIPAA has to be taken in the context of aggregating data, or surveillance, if you want to use the term that's in the news, over multiple covered entities. So we have a situation where patients, particularly ones that are ill, not just the ones that are going to the gym and are doing quantified worried well self, but the ones that cost all the money, basically, in the system, or almost all the money, are dealing with multiple covered entities now. And so, again, from the point of view of good healthcare and good research, what is your view, both of you, as to how we aggregate this data into a way that it's useful for both purposes, given that this covered entity relation, the definition, and the business associate relationship was never really designed, as I understand it, to deal with this aggregation issue?
Okay, I'll take the first stab at that. Yeah, there are two different things. The business associate is acting as an agent on behalf of its principal, to use legal terms. It's acting on behalf of the covered entity. And so
Of
you're
one
only
covered
doing,
entity.
I'm sorry?
Of one covered entity. A business
Typically,
associate.
it could be more than one. There are some hub and spoke relationships out there, but typically, you're right, it's typically one. It could be more than one, but it's usually one. And so whatever's happening with that data is only going back to that covered entity because, as Andy correctly pointed out, you're just acting as an extension of the employees. Okay. So putting that one aside, I think, though, to get the aggregated data, that's what we do. That's where we get the de-identified data, which can come from multiple sources, and you take that data, you can link the patient through a very convoluted and complicated method of de-identification where we actually have multiple layers of encryption, one-way hash algorithm that doesn't reverse, and so multiple layers of doing the de-identification with multiple keys not held by us, keys held by other business partners that contractually cannot share the keys with us. They can't talk to one another. I mean, it's a very complicated picture of how it all works. But at the end of the day, after multiple layers of encryption and multiple security protections being put in place, you can amass the data and aggregate the data to follow
So it is
trends.
Identified. It is
No,
just
it's not identified. It's
if you
never
can-
identified.
Okay, so let me ask, and I'll stop. I don't want to monopolize this. I've tried to get information from one of your large competitors about this technology that you just raised now for the first time, and I have been unable to do that. So there is obviously technology that is used by the industry in order
Yes.
to aggregate data
Yes.
and still claim that it is de-identified
Yes.
when they get it.
Yes.
What is the responsibility of the industry to actually be open as to what that technology is, what its relationship is to HIPAA? And I don't really expect an answer, but
Oh,
I'm
I've got
saying-
one for you. No, I feel pretty strongly about this. And as I said before, I think I work for an ethical company, and I think we like to consider ourselves to be a leader in this. Patient privacy is important. This company's had a chief privacy officer for a number of years, even though it's not a required kind of thing. So I think the difficulty that you're having is probably because a lot of the actual technical details are proprietary. There's patents out there. So our competitors perhaps and us perhaps aren't going to give the exact details down to the minutia on some things that are patented. However,
Patents are public.
pending kinds of patents, because everybody is also out there. Well, you know more than I do about patent law then at this point, but I do know there's proprietary things. There are proprietary things that are sometimes not shared initially, and it could be part of the reason. I see no reason whatsoever why we couldn't explain, as I've just done, the process. The process, it's convoluted and hard to understand. Diagramming it is even more difficult to do. But why wouldn't we be transparent about how that happens if we believe that we do a pretty good job of it? And so we've actually partnered. There's an organization called High Trust. It's a Texas-based organization that's an amalgam of all different kinds of healthcare companies that way back when saw the need for good security in health information exchanges, because if different organizations are going to be touching patient data, you've got to be pretty sure that they're doing a good job of it. We've partnered with High Trust to create a working group that defines levels of de-identification, best practices around de-identification, who the experts should be, what their credentials should be, because we saw that as something that was lacking in guidance these days. So I think absolutely you raise a great point. We all could do a better job of being more transparent and taken to heart.
Michelle, anything to add?
No.
Okay,
Question.
let's go to this side. Another question.
Hi, my name is Robin Candell. I'm from Booz Allen Hamilton. I guess I have a comment and a question. My first comment is I'm a little bit troubled by the earlier discussion that kind of mixes together clinical research with big data, because there are very different, there's regs under HIPAA as well as under the common rule that protect the data under clinical trials and clinical research. But I am intrigued, and I like the discussion a lot about big data, so I'd like to pick up on that point, and I think a point that was raised yesterday about the lack of regulations for de-identified data for analytics. So I'd like to ask Kim, I think you raised the point that your organization has a privacy officer, even though that's not required under HIPAA. I think that's great. You raised some other things that you all do, and I think some of the fears that Michelle is raising is organizations other than yours that don't do those things that perhaps the regs out there, because HIPAA doesn't apply to them, don't require. So my question is, you mentioned that you do analytic, or let me take that back. You de-identify data for covered entities under a business associate agreement, and my presumption would be that you probably don't do analytics on those, or if you do, you probably have some rules in place.
No, I think that the work we would be doing as a business associate would not be to de-identify for a covered entity so much. It's usually already, that data's, when we get de-identified data, it's already de-identified before it comes to us, either at the supplier site or by a third party, not us. So we receive it in de-identified form. When acting as a business associate for a covered entity, it would be identifiable data just acting as an extension of the covered entity.
Oh, okay. That helps clarify it, because business associates can de-identify data.
Yep, absolutely, but that would not be our typical model.
Right. So analytics is totally separate and distinct from that type of work that you do?
Whatever we're doing for a covered entity could be soup to nuts. You know, I can't tell you exactly what they're asking for because it's kind of not my business. And most of what we do is also need-to-know basis, too. So, you know, I don't know exactly what a particular covered entity would want us to be doing. But we would have a business associate agreement in place, handling the data separately and apart under HIPAA-controlled circumstances.
Okay,
Thanks. Another question.
Scott Mace with Health Leaders Media. I have a question for Michelle. So how much control are you asking for patients to have over their de-identified data? Can you clarify that point? Are you asking for all of that to go through a consent process?
Yes, basically. I think,
Okay.
but listen, I think the key is that there are tools that make that not sort of this giant group of complicated decisions for a person, where you can say, I'm okay with this data being de-identified and going towards, you know, research of this type or that type, and I'm okay with that, but that I get to have that permission each and every time that data is shared would be a crucial part of that.
Okay, here's my concern. I mean, I write for healthcare providers who are trying to practice evidence-based medicine, and so they're looking at a data set now that will consist of some data that some consumers in your world have agreed to allow to be used as this de-identified data set, and other data that isn't. So isn't that skewing the evidence in the evidence-based medicine?
I don't actually really know because I'm not a clinician, but I can tell you that the evidence probably is already skewed by the fact that there is evidence that people withhold information. There's actually, I think some crazy amount of deaths every year in our country because people don't get the care that they need because of that issue. So I wouldn't necessarily assume that the information when you don't ask somebody is still accurate. In fact, I would argue the opposite. When you have patient control and consent, you know that data, or you have a much better sense that data is accurate. So I would say that it is actually culling better data for researchers.
Thank you.
We do want to distinguish between the clinicians and the researchers, though, although sometimes there are researchers who are also clinicians. But
Yeah, sorry.
Yeah, the patient,
Not a doctor.
yeah. But that is a figure. Deborah, what was the figure you gave me of deaths caused by?
I don't have a figure for death.
I do, somewhere.
Okay.
We don't have a figure for deaths, but we do know that 1 in 8, or 37.5 million people, hide information every year. That's a huge number. And that's comes first from California Healthcare Foundation in 2005, was repeated in 2012. We also know from AHRQ studies that millions of people every year delay treatment or avoid treatment altogether for very serious conditions, between 5 and 6 million, for cancer, for mental illness, and for sexually transmitted diseases. And so, with hiding information, you get bad data. With lack of privacy, you also get people, who are really literally putting their health and their lives at risk, 5 or 6 million a year. But, anyway.
And then it would be an interesting question to know how many of them do want to hide it from clinicians, or how many of them would be happy to share it with any clinician treating them if they knew it would not go further. And they, as Michelle was suggesting, they might not trust the de-identification process and might be afraid that their insurer or employer would get it and so forth. But I think we should turn to another question. I think it's your turn. Yeah, we should have time for both of you.
Peter Bachman, Seagulls US. I think there's some very easy simplifications to this debate that were obscured by our panelists here, our debaters. But there's a point where this all comes together. I don't want to invoke Godwin's law. We won't go there. Okay, that's the obvious elephant in the room in terms of consent of subjects for medical research. But we can just say that as a starting point.
Sorry, what is that?
Godwin's law is an internet. You can look it up. You can figure out what it is. So, moving past Godwin's law is that we have a whole ethical framework for patients giving consent to research. Tuskegee, you mentioned Tuskegee, classic outlier example of that. So, patients generating data is an HL7 template. You can go to hl7.org. They have a method of doing a consolidated CDA. A patient can generate data into an EHR, and the EHR can accept that. That's not a problem now, except in the structure of the medical hierarchy that does the paternalism, as you mentioned. So this idea that was validated yesterday by the ONC said, yes, we'll accept data coming back as a return. To simplify that, to give the patient the consent to share data when they want to voluntarily participate, they're going through a huge system like IMS Health. To use a particular example, look at NHS. NHS provides a de-identified data set. That de-identified data set is de-identified. There's no question, and there's not a question about the mathematics of the de-identification, OLAP and all that kind of stuff. The issue is the patients who are going to NHS in the UK that provide the data here through the data aggregator in de-identified form really don't have a choice in terms of opting in or opting out. There is no consent because the doctor is incentivized for quality reporting. So they will lose money at NHS if they don't provide that data into the system. So as far as there being meaningful consent, which we already agreed doesn't exist, can meaningful consent exist under this concept you're raising? Excuse me.
I'm afraid I don't quite understand your question. Would you mind just sort of boiling it down?
From an ethical perspective, the ethical perspective says you need meaningful consent. We already agreed under HIPAA doesn't provide that. You sign the form in the doctor's office, and there the data goes, and there's no controls after that. The doctor who's providing the data for a de-identified data set is incentivized to do that through quality measures. If they don't do that, they won't get the money because they don't have the quality reporting requirements done. So they're incentivized to get everybody to opt in. There is no incentive for people to opt out.
Right.
So even if it's a de-identified data set, there's already self-selection taking place.
Oh, okay. So you're really making that point, not asking a question.
But there are certain principles that public health officials can get data even if people don't want to give it.
Absolutely.
So this might fall under that.
No, absolutely correct.
And I think one of the things that we need to consider is something similar to an IRB in-house at a lot of the commercial organizations. Yeah, I actually brought that up the other day. I was presenting at a Datapalooza conference, and that's one of my thoughts, is not exactly an IRB, but an ethical board of some sort at the various organizations to consider those very kinds of questions.
At the data source for the data subjects.
And I would say even beyond at the data source, I think even when we're receiving.
Right.
Let's get the last question.
Thank you. My name is Albert Dane, and thank you, Kimberly, for clarifying and explaining these key elements of your company's business so that I much better understand that you serve sort of as an IT department, health IT department, for those business associates who want to share identified data with you, and that doesn't leave that relationship. But you also have de-identified data sets which, through the magic of many layers of handoffs and hashtags and keys, and I get that, and at High Trust, which is a great institution independently helping with all of that, you can reconnect de-identified individuals. Is that right? An individual in one data set who's de-identified can be matched with other information about them that came from another provider in another data set that's also de-identified.
Right, you can link, but where you have to be cautious, and one thing I probably didn't say enough about too, you've got to be cautious in your linkage because you always need to still maintain the de-identification. So for example, there are certain things, data elements perhaps, that might be red flags that you wouldn't want to bring in because you're always working under that threshold of a very low risk of re-identification. You're always trying to manage to the very low level risk of re-identification. So could it happen? Yes. Are we very cautious about what data is commingled and what isn't? Do we have experts, third parties unrelated to us that validate? Absolutely.
Okay, so my question is, beyond this work, is your company engaged at all in selling access on behalf of the people who gave you the data to other partners? In other words, when you merge these data sets, are you selling access to those data sets to outside parties who may not have generated any of this at all, like advertisers who want to, or brokers who want to reach, do research for marketing on these sets, not health research?
It depends on the data set. If it's a very aggregated, safe kind of data set, absolutely. You know, you can Google us and see that we're quoted by, all kinds of governmental bodies, all kinds of customers, FDA, CDC, you name it, use our data. If it's data that we feel would not be appropriate because of maybe not trusting the recipient or, thinking that there'd be an increased risk of re-identification, not necessarily. I mean, it absolutely depends upon the data set.
We have to wrap up. Let me
you.
just ask Michelle if you have any last thing to say.
I do. Thanks, Kim, for coming into the sort of nest of advocates, it seems. But and I appreciate you answering all my questions, which I know some of them were sort of pressing. I still feel like I don't quite understand IMS's argument for not asking people's consent. I understand the technical part of it, but not the ethical part of it, and not the fact that the company's so not transparent. And I actually think that overall the healthcare industry is dangerously behind the times when it comes to patient control and access. I think the stage has already been set. There's a survey by Accenture recently that said 1,100 U.S. patients, or of 1,100 U.S. patients, that showed 90% of them would prefer to use the internet, mobile devices, and email to self-manage their own healthcare information. We all understand that. I mean, I think that's where it's going, and yet our healthcare system as it is today, including the business side of it, is completely fractured and scattered to the point where I doubt that even IMS knows exactly where every piece of data that it holds, where it goes, and how it ends up affecting a person. I don't know whether the company uses sort of the same thing as Axiom, where they have the poor, poverty-stricken single mother kind of attributes, but that kind of distinction is exactly what leads to harms, including things like insurance rates going up, people being actively affected by it, by employers seeing medical diagnosis. And when you use things like social media, it's very difficult to get those distinctions removed, or if it's an error. Just one more minute. The thing is, and not only do I think this reluctance doesn't make a lot of sense except outside of the business of making money from the data, I think it keeps those already on the sideline of healthcare in the shadows, the traditionally underserved communities that I talked about. There was a report from Pew recently that showed that older, less affluent seniors with health and disability challenges tend to be disconnected from the digital world. And so, without these tools for patients who desperately need it, and then without the actual control of consent and accessibility and transparency, I think you're just basically pushing people to the sidelines even more.
We're getting into a lot of other areas. So I think we need to give Kim 30 seconds.
I only need 20. First of all, thank you, Deb and the PPR, for having us be here today. We are all on the same team, and I hope that comes through loud and clear, that we very much care about patient privacy. We would not be here supporting this. I would not be here on this panel. We would not have sponsored breakfast this morning, for example, if we didn't believe in this being an important thing. We're trying to work very hard. We believe it's very important that private industry, that government, that advocacy groups, that we come together and discuss how we feel. And as I said in the beginning, I'm actually surprised we had as much disagreement as we do, because frankly, I think this is an excellent opportunity for us to all get together for the good of the patient.
Thank you. Thanks, everyone.
Thank you, Kim, very much. Thank you, Michelle.